So we're going to tag team. First, a few observations. That, as has been pointed out here quite effectively, what we really have is a natural experiment with nearly identical interventions variably implemented in now somewhat divergent populations. We may be able to learn from that. How do we evaluate a paradigm shift that is an anathema to some and considered essential to others? This is a question that we should take to heart. This meeting has, I think, begun to scratch the surface of that. How do we have that conversation? Physician aid in dying raises a number of questions that can create skepticism about current practices that we sort of didn't have skepticism about. How certain are we about the capacity and undue influence in withholding and withdrawing decisions that we do in our hospitals every single day? How even-handed and are there conflicts of interest in treatment decisions? Very aggressive treatment decisions that are decided between oncologist and patient, between CT surgeon and patient in our hospitals every single day. What's the general approach toward persons with disabilities? Can we focus, do we focus, Joanne brought into focus the fact that we are so comfortable focusing on the medical model, probably because it's just too painful to think about the social determinants. The PAD request is a really powerful request, right? It stimulates a cascade of communication and intervention that appears to be missing in routine care. I received a call this morning from a primary care doc at my institution telling me that she had the most meaningful conversation with a patient of her entire life, and it was about this topic. Why did it take until now? The existence of PAD has broad-reaching effects. There's much attention to resources, despite very, very few patients. And health systems are expected to put up resources far outweighing the number of patients that will be affected. And it may enable other discussions about advanced care planning and palliative care. But as is evidenced in this room, there appears to be a scary, slippery slope.
So thanks. I just had one last observation. It seemed coming into this, I was hoping when this was first being planned that we'd be able to talk about sort of micro and meso level issues without as much focus on the macro issues about moral status as well as some of the other things. But I think this meeting has shown that that's impossible, that they all these levels wind up being intertwined in different important ways. So we talked a bit about what from our panel, from our session, our two panels, what are some of the areas for future research? What are the implications? So it was discussed how there are different kinds of expansions in different jurisdictions outside of the U.S. So one area of research is going to be what the impact of those things have as they come online. Thaddeus Pope talked about some of those things yesterday. What's it going to mean when it's expanded to minors, when the terminal requirement is either broadened or eliminated, the self-administration requirement or allowing advanced healthcare directives. If these changes happen, what are the positive, what are the negative implications? Really being able to dig into what those things are is something that's a future area for research. Other future research, understanding the benefits and burdens of the lawful process better. What harms occur because of the fracturing of continuity as a result of physicians or institutions opting out? As was pointed out earlier today as well and was discussed at both of our panels, physicians often opt out and we don't really know very much about what that means for the patients when they opt out, both for access and for different aspects of the quality of the care. So that's something that needs to be studied further. The impact of medication challenges, especially as medications for PAD are changing, as the shift from segobarbital to other options are taking place. Issues of cost, logistics, side effects need to be explored more. The impact of the 15-day time delay and other logistical barriers to access, which we talked a lot about in our panels, and the need for digging in and understanding those better, as well as the impact of not allowing family to be present for the private conversation. So those are all things that our panels discussed. Above all, and this is something, it alludes to something that Neil mentioned, what's the ancillary impact of PAD laws on care for people besides this very, very tiny number of people who are accessing it. The qualitative data presented from the Netherlands on the first panel that we had suggested that it was actually an opportunity for improved communication among a broader range of people than the people who actually accessed euthanasia, that only a minority accessed them, but it improved communication. But this flies in the face of some other data that from Oregon that seems to suggest that that does not occur. So is this finding applicable in the U.S. context? Can the impact on clinical care beyond those who receive PAD be measured? And is it improve or decrease in quality of life care generally? There's certainly a lot of concerns that it might make things worse rather than better. So trying to really dig into whether or not this is making things better or making things worse for other patients besides the patients who are actually getting it is something that I think needs to be studied and as has been said, is going to be very hard to do. And if there is, has been alluded to in our conversations and subsequently, if there's something about PAD and other similar practices that leads to increases in resources, time, communication, that leads to the best communication they ever had, what is it about PAD that makes that happen? Is that something that we can titrate out and export to other kinds of contexts be outside of the PAD context? So really digging in and understanding why is it that it's only in these contexts that some people are thinking that they're having the best conversations happen or resources are being mounted that otherwise wouldn't really be there. We also need more better data on alternatives. So there was a discussion about the importance of digging in more for data about the various practices around proportional palliative sedation. Tim Quill talked about that, as well as palliative sedation to unconsciousness and the range and practices in that area. There's been some studies and some data about VSED, but again, more study and more data of all these alternatives besides PAD and end-of-life options, and more study of all of those things need to be done. How are they being used? What are the policies and practices governing their use? And what are the implications of all these other end-of-life practices, which we need to study more. Impact on the disabled, the need for better data about the views of the disabled community. There's a little bit of quantitative data about disabled communities' views about PAD, but it's not very good quality. So we need better data about PAD among patients with disabilities. Are patients not getting access to PAD who otherwise would? Are patients getting access to PAD who otherwise would not? Is there evidence that PAD is having ancillary negative impacts on care for the disabled patients? Again, I think all those things need to be studied in more detail. And then the bigger issue that Neil alluded to a second ago about the extent to which long-term legalization in Oregon changed the nature of perceptions and what extent is this actually having an impact on moral dimensions in the society. It was mentioned by, I think, Peter, that this is just not an ethical debate anymore in Oregon in the same way that it used to be after they've become more familiar with that. Is that real? We need to really study that more and understand if that's happening, and if so, why? Is that something that's happening broadly because we see broader changes, or is it actually passing a law really does produce profound changes in the ethos of a culture? What are the effects on clinicians who participate and those who do not, which we don't know very well? What are the effects on institutions that opt in or opt out? That's not really been studied very much as well. And then developing best practices. What mechanisms exist to support providers in carrying out PAD? Which practices and policies in the area work best? What other differences in policy and implementation exist and what works best? Mandatory psych screening, role for palliative care, role for ethics, mandatory navigation. To what extent do participating institutions believe they have an obligation to identify a provider if a patient's physician chooses not to participate, and how is this obligation carried out? All those kind of institutional questions about how this is actually being implemented and what it means when you implement it in a certain way is something that needs to be studied further so we can actually see the real-world impact of one approach versus another.
So not all of these questions, but many could be addressed if we did some sort of a case-controlled trial. This is a natural experiment. Some states permit aid in dying, some do not. And within states, there are differences in the implementation. One could identify patients with terminal conditions wanting aid in dying across 3 states permitting, 3 states not permitting. The difficulty, of course, would be in finding patients who want this not necessarily patients who get this. Stratify by healthcare organizations, opting in, opting out. We could evaluate the end-of-life care received by patients and the effect on families and clinicians, maybe even to answer some of the questions that Dr. Somesi put out at the beginning. If there is a relationship between empirical data and whether acts like this are acceptable, that might be doable at a population level. Patient symptoms and hope and depression, anxiety. We have bereaved family surveys available. We can study course of treatment, goal concordant care, and physician outcomes. Thanks.